Assalamualaikum and good morning to everyone. So today my friends and I are going to present on shoulder labral. First, let's take a look at the anatomy of the shoulder joint. The shoulder joint is made up from three bones which are the shoulder blade, the collarbone and humerus. The shoulder joint is considered as ball and socket joint. The socket is referring to glenoid fossa of the scapula, which is shallow and small, that covered at most only a third of the ball, which is referring to the head of humerus. The socket is then deepened by glenoid labrum. Glenoid labrum is a fibrocartilage of the shoulder joint which anchor to the joint capsule and shoulder ligaments. It provides static stability to the glenohumeral joint. The capsule of the glenohumeral joint attached to the glenoid labrum. The glenoid labrum is continuous with tendon of the long head of bicep superiorly and attached to anterior band of the inferior glenohumeral ligament anteriorly and also attached to glenohumeral ligament in the middle part. Most instabilities or pain syndromes are associated with injuries or morphologic changes in the glenoid labrum complex or long head of biceps tendon origin. The labrum is also often involved in shoulder pathology, either by single trauma or more often repeated microtrauma. Labrum tear are usually caused by either falling on an outstretched arm, direct blow to the shoulder, high force overhead activities which usually involve in sports activities, sudden pull when trying to lift a heavy object, or repetitive overhead heavy objects lifting.
The risk factors for labral tear are first, repetitive overhead sports such as baseball and swimming. Second, aging for those more than 40 years old. Third, traumatic injury. Then, degenerative conditions such as osteoarthritis. Finally, glenohumeral internal rotation deficit, which is a condition resulting in the loss of internal rotation of the glenohumeral joint. The pathophysiology of labral tear, first, due to acute traumatic slap lesion, compression, fall onto an outstretched hand, or traction, sudden jerking movements, or lifting heavy objects, or combined. Next is the attritional slap injuries, which can result in reducing strength due to the peel-back mechanism. When the shoulder is in abduction and maximal external rotation, increased stress exerted on the biceps tendon attachment causes separation and tearing of the superior posterior labrum from the glenoid. This is usually occur for the overhead athlete during the cocking phase. And finally is the degenerative slap lesion due to wear and tear.
Physiotherapy assessment. According to Clark et al. 2018, there were 5 special tests. First, bicep load 1, bicep load 2, speed test, passive compression, and O'Brien test. However, in a study by Clark et al. 2018, combination of bicep load 1, bicep load 2, and O'Brien showed a high sensitivity of 0.992 to 0.999 and specificity of 0.992 to 0.999. Most of bicep load 1, first, patient in supine with shoulder abduct 90 degree, elbow flex 90 degree, and forearm in supinate. Then the therapist asks the patient to flex the elbow. Then the therapist will resist the elbow flexion. For the positive result, if the pain stay the same or worsen and abrasion remains, the test is considered positive. The diagnostic properties of the bicep load 1, the sensitivity is 0.9, meanwhile the specificity is 0.96. For the bicep load 2, the performance is still the same like bicep load 1, which makes the difference is the shoulder needs to abduct 120 degrees. For the positive test, the pain experienced during the resisted elbow. For the diagnostic properties of bicep load 2, the sensitivity is 0.9, meanwhile the specificity is 0.97. Next is for O'Brien test. The performance is patients need either to stand or sit with shoulder flexed 90 degrees forward and horizontal abduction about 10 to 15 degrees with the thumb pointed downward. Then therapists need to give downward force, which the patient needs to resist it. The procedure will repeat by the thumb pointed upward. For the positive result, the pain or clicking sound will reproduce when during the thumb pointed downward. Okay, when the thumb pointed upward, there's no pain or click sound. Diagnostic properties of O'Brien, the sensitivity is 0.83 to 1 and the specificity is 0.95. Next, for physiotherapy management, the article written by Ma et al. In 2017 about the rehabilitation after anterior capsuloligamentous repair. The rehab is to restore the glenohumeral passive range of motion and protect the healing tissue. This will allow the greater individualization and improve long-term outcome. In phase 1, which is the immediate phase after the labral repair that takes 0 to 6 weeks, the goals are to protect the healing tissue, reduce pain, correct the postural dysfunction, and promote dynamic stability. In this phase, they will also restore the passive and active assisted RM, which to minimize the effect of immobilization. The first 2 weeks, the passive RM is initiated. The passive shoulder flex can be limited to 60 to 75 degree, external rotation limit to 10 to 15 degree, and internal rotation limit to 45 degree. In this phase, passive external rotation in shoulder abduct 90 degree is need to be avoided. In the 3rd to 4th week of this phase, the ROM can be increased, with the passive flexion limited to 90 degree, external rotation from 25 to 30 degree, and internal rotation from 15 to 60 degree. The light strengthening exercise can be performed, which that includes isometric exercise. A gradual introduction to active assisted RM is also performed in this phase. In the second phase of this protocol, the goals are to restore ROM, begin strengthening exercise for rotator cuff and scapula stabilizer. In ROM, it includes passive and active in all planes that includes internal and external rotation in shoulder abduct 90 degree. Leg strengthening exercise for external rotation and scapula stabilizer are performed, with also can be include blood flow restriction training and an MES during the strengthening exercise like figure 2. Additional strengthening exercise can be initiated after 10th week of post-op. In this phase 2, there have throw stand program that involve athletic activities. This program involve impact towards the shoulder. This program only can be initiated when certain criteria are met, like full active ROM, improve in shoulder dynamic stability, and muscle strength 4 to 5 or better with no pain. The third phase of these protocols, which is minimal protraction after the repair, the goals is to restore full ROM, improve muscle strength that necessary for sport or work. First, plyometric exercise can be initiated, but start with low velocity and then progress to medium velocity. Strengthening exercise are continued, but advantage from previous phase. Cross-body internal rotation stretch can be done to maintain internal rotation range. In the 16 weeks of this phase, plyometric exercise is advanced to high velocity. Sport program includes throwing, swimming, or overhead sport may initiate. However, who are not involved in overhead sport may return to the sport. However, for overhead athlete or thrower are not able to fully return to the competition until 7 to 9 months of post-surgery. In another article by Goldenberg et al. In 2021, they include a protocol that involves 5 phases, which the individuals need to pass all the criteria in each phase to progress to the next phase. These are the goals in each phase of phase 1, phase 2, phase 3, phase 4, and phase 5. In the first protection phase, there will be initiate passive range of motion to prevent stiffness and typically limited 120 of shoulder flex, 90 degree of abduction, 90 degree internal rotation, and 30 degree of external rotation. And there will be a dynamic glenohumeral joint stabilization that involves rotator cuff and scapulothoracic muscle. Isometric exercise have been introduced in this phase by starting 25% of maximal force. Lastly, the criteria that need to be achieved in this phase: first, the pain must be low, the 3/10, and dash score must be low 60%, passive RM of flexion, abduction, and external rotation, include able to do scapula club. When these criteria are achieved, the individual can progress to the next phase, which is the second phase. In second phase, active assisted RM can be done, and active RM is progressed at week 6 with full pain-free motion. Open kinetic chain exercise and PNF also can be initiated. In this phase, if capsular stiffness and shortening of shoulder muscle, manual technique can be done like gentle joint mop. The criteria needs to be achieved so they can progress to the next phase. The next phase are pain must be below 3/10 in active RM, dash score below 40%, active RM in shoulder and abduction 120, external rotation is 45 degree with normal scapular movement, and lastly able to perform 20 repetition of scapula plane elevation, abduction, and external rotation. In the third phase is initial resistance strengthening. The exercises are same like in the phase 2, but with adding resistance band or TheraBand or light free weight. The criteria that need to be achieved to progress to advanced strengthening are: dash score must be below 20%, active range of motion of flexion, abduction, and external rotation must be almost 90% like the unaffected side, and MMT must be 4 or 5 or greater, and the hand anemometer must be more 80%. In fourth phase is advanced strengthening and power. In advanced strengthening exercise, standing resisted external rotation can be performed. We start with 45 degree of shoulder abduct and then can progress to 90 degree of shoulder abduct. Standing internal rotation with shoulder abduct 90 degree can be started. Closed kinetic chain also can be performed. Once the criteria in table 4 have been achieved, the individual can progress to power exercise, which is plyometric exercise that can be performed that mostly occur at the 5 months of post-op. The last phase is to return to sport. The criteria that need to return to sport are able to do wall plyometric bounce, single arm shot put, CKC upper extremity test, and upper extremity Y balance. When the test passed, the surgeon and physiotherapist decide if the patient is ready to return to sport.
A randomized control trial conducted by Hill et al. In 2020 aims to determine if the addition of upper quarter dry needling to a rehabilitation protocol is more effective in improving range of motion, pain, and functional outcome scores when compared to a rehabilitation protocol alone after shoulder stabilization surgery. They found out at 6-month follow-up there was a statistically significant improvement in shoulder flexion range of motion in the rehabilitation group. However, both groups showed improvement over time, but the addition of dry needling in the standard care of rehab did not significantly improve shoulder range of motion, pain, or functional outcome scores when compared with standard of care rehabilitation alone. Schubert and Doral conducted a study on the treatment used in posterior shoulder instability in the throwing athlete in 2021 using a protocol based on Kircher et al. Study. Immediately after the surgery, the patient is allowed to remove the arm out of the sling for light activities of daily living. 2 weeks after the surgery, the patient can be introduced to low-impact cardiovascular exercises such as walking and stationary bicycle. 3 weeks after the surgery, the patient can be introduced to RM exercises that can be progressed as tolerated by the patient. The resistance exercise can only be prescribed to the patient 6 weeks following the surgery. For baseball player, a throwing program is initiated at 4 months if the strength and ROM have improved sufficiently to allow for this activity. Hitting of a tee training is allowed at 3 months if the operative shoulder is the back shoulder, but not until 4 months if it is the lead shoulder. Unrestricted activities are allowed at 6 months, including diving onto the operative arm.
We proceed to the next physiotherapy management. So this is an experimental study by K. Matan Kumar in 2019. Population is 20 athletes from various sports aged between 20 to 38 years with post-operative slap tear. The objective of the study is to determine the effectiveness of dermoneuromodulation on pain reduction and improvement of shoulder internal rotation among post-operative slap tear athletes. The outcome measures are numerical pain rating scale and goniometry of shoulder internal rotation. The measure is measured at pre-test and post-test after 4 months. So for NPRS, Group 1 is more than Group 2 in pain reduction. Group 1 from 8.1 to 0.7, Group 2 from 8 to 2.3. For shoulder internal rotation range of motion, Group 1 also more than Group 2. Group 1 from 26 degrees to 66.5 degrees. Meanwhile for Group 2 from 35.5 degrees to 48 degrees. So this is the intervention for Group 1 and Group 2, both with 10 participants. Group 1, neuromodulation with conventional physiotherapy, and Group 2 on the conventional physiotherapy. So what is neuromodulation? From the name itself, dermo meaning skin and neuro meaning the nervous system. So this intervention will touch the skin to interact with the nervous system and effect change to pain and function. So for the neuromodulation session is for 10 minutes, 1 session per day, 3 days per week. The patient position is side lying with hand on the chip with forearm pronated and elbow on the air. Therapist position sitting behind the head of the patient. Hand placement, left hand over the lateral border of the scapula and right hand over the elbow. So the procedure is the therapist will press gently and continuously to move the scapula medially. Move the skin over the elbow upwards towards the other hand. So both of the hand will go to the same direction. Hold between 2 to 5 minutes and remove hand slowly. Ask the patient to perform internal rotation actively while standing. Next is the conventional physiotherapy for both groups. First, there is an immobilization period for 1 month. Only pendulum and elbow ROM exercises is permitted. Next is the 4 weeks. 4 weeks post-op, assistive and passive exercise. 5 to 7 weeks post-op, internal and external rotation increase progressively to 90 degrees of shoulder abduction, and 8 weeks of post-op, resistant exercise and scapular strengthening, and finally 4 to 6 months post-op, sport-specific training. Okay, for the next management is a study of accelerated rehabilitation after arthroscopic blanket repair in professional footballers. This is a study by Gibson et al. In 2016. The study design is a prospective single series. Population is 34 professional footballers following soft tissue stabilization for traumatic anterior shoulder dislocation with labral injury. The mean age is 23 years. Objective of this study is to assess the efficacy of an accelerated rehabilitation program for professional footballers who underwent early surgical stabilization for their first time anterior dislocation in terms of clinical result, return to play statistics and recurrence rates. So for the outcome measures measured at a mean follow-up time of 4.8 years. First, they will measure the time to regain full forward elevation range. The results measured in mean is 5 weeks. Next is the time to regain external rotation range in 6 weeks mean. Next, return to playtime in 11 weeks and rate of recurrence at 9% at a mean of 90 months. Okay, the study shows that 11-week return to play period compared to previously reported times in the contact sports population of between 5 and 9 months. Okay, so this is the accelerated postoperative rehabilitation procedure. First is the phase 1, 0 to 4 weeks, started at second postoperative day. Active assisted mobilization within safe zone based on passive range achievable without undue stress on surgical site. 120 to 140 degrees of elevation anterior to the scapular plane and 50% of preoperative external rotation range in neutral elevation. Next, they will do the closed kinetic chain or proprioceptive exercise, isometric exercise for rotator cuff and scapula, wrestling for 2 to 3 weeks, cardiovascular fitness exercise, bike or inclined treadmill walking, no combined abduction and external rotation, no force and range motion, especially external rotation with arm at the side. And lastly, progression based on goals, pain, scapular congruence, movement pattern and passive ROM, and patience. Okay, next is the phase 2 from 3 to 10 weeks. Progress rotator cuff and scapular active mobilization through range and wrist positions. Progress strengthening with kinetic chain integration. Close kinetic chain exercises into danger zone. Progress cardiovascular fitness exercises. Running and non-contact drills. No passive stretching into combined abduction and external rotation. And finally, the late stage from 6 to 16 weeks, function-specific strengthening and endurance exercises, progress strengthening through range, isolated and combined with kinetic chain, close kinetic chain exercises into danger zone, increased load and perturbations, function-specific plyometrics, controlled falling drills, and a progressive return to full contact training. So this program is only as a guide because it is not time specific but patient specific and goal driven. So some patients may progress faster than others. That's all from us. Thank you.